sure he will actually sometime rather tell people actually how much, but it was actually a massive amount of money. And that was enough to actually set us off in setting up the MECFS Centre. So I think Dwight, you need a round of applause. Without Dwight's help, actually, the MECFS Centre wouldn't exist, and actually we wouldn't be having the second conference. Now, if I'm going to try and find it. It's going to actually touch on some of the things that Eric actually talked about, some of the things that Judy talked about, some of the things that Dan talked about, and some of the things perhaps that Nancy will talk about. It's going to be talk about actually the methylation cycle. And I'm actually doing this for two reasons, because one, we have an interest in it, and second, because it's in honor of Rich van Koinenberg, who actually gave a wonderful presentation at our last conference. He would have been invited back again today, but unfortunately he died actually about 3 months after the last conference. A great loss actually to MECFS research. So let me actually go back actually. This is not an American invention. People actually think that this is an American disease. That, people actually decided that Americans actually are somewhat fallible and only Americans actually suffer from this disease. In fact, the genius of Melvin Ramsey was that he actually had a group of medical students, young doctors and nurses in the Royal Free Hospital in 1955. And they actually suffered from this unknown, massive, debilitating disease. They didn't know what it was. In fact, actually some of the staff, some of Ramsey's colleagues thought actually that the patients were hysterical. In fact, actually, they even thought that Melvin was hysterical because he was actually diagnosing this disease. And they didn't know what to call it, so they initially called it the Royal Free disease, not because actually it's noble or not because it was free. It was because the hospital actually was the real Royal Free Hospital. And then they actually decided, well, there was a lot of patients had Coxsackie B virus, so they called it the post-my patients, is it, Julius?
Yeah.
Sure. Wonderful. Thank you. Thank you, Jerry. I don't know what I'd do without you. That's why I'm treating well. So, post-viral fatigue, actually, then he actually said, well, it's possibly actually not everybody has this Coxsackie B, so we'll call it myalgic encephalomyelitis. Myalgic because it affects muscle, and encephalo because it has some sort of peculiar relationship to the brain, and myelitis, well, it has some actually other CNS problems. And then actually there's been this discussion actually, which has been ongoing for 50 years, actually, well, it's not really inflamed, it's not really actually the brain, it's not really. And they actually started going on myalgic encephalomyelitis. I mean, the Icelandics actually had a better idea. In their outbreak, they called it Icelandic disease. And then actually, Dan actually had this cohort in Inkang village, and the term chronic fatigue syndrome was coined. Then actually, people have been trying to actually determine, well, where is this actually problem? Is it actually in the transcription? Is it in the DNA? Is it in the messenger RNA? Is it in the ribosome? Sarah Mayhill actually says, well, maybe it's in the ribosome, and it's actually a problem internally in the cell. Actually, in the cell actually then abnormally produces protein. What is the pathogenesis of the disease? What causes this disease? Well, and what are the causes of this disease? What does it do? Well, it actually, as Nancy Klimas, who we're going to actually hear from next, has actually done massive research and shown actually that there is immune system abnormalities. There is great pathology in the immune system. The Th2 phenotype, and the latest actually idea is that there is cytokine abnormalities. Maybe it's actually a cytokine storm. Maybe actually it's not just an imbalance of the cytokine. Maybe actually the cytokines actually are creating a storm. What's causing that? Well, we don't know. We heard actually Judy talk at length and very well on various viruses. We'll talk about various viruses in a moment. And other people actually have thought maybe it's bacteria. And Crooks actually wrote a book saying, no, it's not bacteria, it's not viruses, it's actually Candida. Well, I think that's being laid to rest because a lot of patients have Candida, but a lot of patients do not. So it's not actually the sole forming abnormality in this disease. In the nervous system, there's paresis, there's visual loss. In fact, actually, I have a patient who's in the audience who had HHV6 uveitis and actually was blinded by the HHV6 infection. We treated actually, we sent her actually up to Chang, who's the head of ophthalmology at Columbia Presbyterian, and Chang actually said, oh yeah, she's got uveitis, it's probably viral. Well, you know about this. You treat her. I said, I'm not an ophthalmologist. He said, well, we'll do it together. So we treated her with Falsight, and now she has 20/20 vision. Wonderful. There are other abnormalities in the brain scan. We're going to actually see a peculiar set of abnormalities, which I actually discussed with Byron Hyde about 2 or 3 weeks ago, and I'm going to finish up the talk actually going in that direction. Other endocrine system abnormalities in the hypothalamus pituitary adrenal axis has been actually touted for many years. Cardiovascular problems, we know about POTS, we know actually that there's vasodilation, we know actually there's abnormal lowering of the blood pressure. Psychological function, this is one of my favorite things. This is a physical disease. This is not a psychological disease. Yes, you can actually be depressed in this disease. It's all secondary. This is
Simon Wesley's
not
calling.
A disease actually devoid of depression. There are massive chronic diseases, sarcoidosis, tuberculosis, leukemia, cancer, and all of these diseases actually might have secondary depression. But nobody will actually suggest that leukemia is caused by depression. But in this disease, people say, oh, this disease is caused by depression. And there are a certain group actually in England who have made actually a reputation from saying this is pure depression. We'll actually treat them actually with cognitive behavioral therapy. We'll actually make them exercise and they'll get better. Well, we'll see in a moment actually that that might actually be completely the adverse possibility. Genetic predisposition. Now, I believe actually that Eric is on track actually with getting a Nobel Prize within the next 10 years. And that's what basically he's thinking. He thinks actually that there might be an abnormal gene in this disease. And that is based on some work that Jonathan Kerr did. And we'll actually touch on that a little later. So, virus is a cause of infection. Why? CFS often starts with a flu-like episode. CFS symptoms wax and wane. The antiviral pathways are activated. CFS symptoms are similar to many viral conditions, including mono, EBV mono, Ross River virus disease. Geographical outbreaks have been reported in Klein Village, Iceland, Australia, World Free Hospital. Gene expression profiling has found genetic variants that impact antiviral defenses. And antiviral treatments, as Dan has very effectively actually listed, include Ampligen, isoprenazine. By the way, isoprenazine is made in Ireland. You can determine from my accent why I'm actually saying that. Beta interferon and Jose Montoya's signal research on HHV6 using Van Gang cyclovir pulsate. What are the viruses that have been implicated? EBV, cytomegalo inclusion virus, human herpes virus 6, human herpes virus 7, stealth virus, enterovirus, polio. I mean, there's a whole list of various viruses that have actually been implicated, including actually the retrovirus at the end of the list. And this actually is not only due to actually Judy's excellent research, but actually was suggested by Elaine de Freitas 18 years ago. Yeah, for Elaine, actually, she actually had to drop out of research. And of course, actually, as I said, the initiation of the XMRV in Nevada. HHV6 was discovered in 1986 by my friend Ablashi, and he actually defined that there were two types, A and B, and actually each variant had a different subset of the illness. And basically, one of the disturbing key immune activation pathways was seen in this virus. It depleted the CD4 T lymphocytes. It upregulated TNF alpha, TNF gamma, IL-1 beta, IL-10, and IL-21, and downregulated. I mean, it did a job, as Dan said, on the immune system. Now, the interesting thing is that HHV6 is omnipotent. It actually can go places that other viruses have difficulty. Here is HHV6 in interstitial cells. This is basically in interstitium in the body. And the next to the right is HHV6A in the actual left ventricle of the heart. And interestingly, here is a beautiful photograph. I think actually one of my favorite photographs in medicine, because it actually was hanging on a wall. It's an infected astrocyte in the brain. We're going to come back to this particular slide a little later, because it has got implications on the last part of the talk. What do we actually do for this? As Dan actually said, Ampligen, isoprenzine, alpha-2 interferon, Zovirax, Valtrex, Valsite, hepapressin, immunoprophylactic. These are all methods of treatment that have been looked at. Why? Because we believe actually in the immune system, according to Rich van Goynenberg, the methylation cycle was at risk. Now, this is a very actually complicated slide, and I'm actually showing it not to actually be able to define actually the various metabolic processes, but to show that it is indeed complicated. And the complications actually are basically due to an almost universal glutathione depletion. Paul Cheney actually described that in 1999. And as I said, Goynenberg said that some of the CFS symptoms can be explained by glutathione depletion. And we've actually had personal experience from our patients with supplementation of the methylation site. Hepapressin complex is basically derived from the old Q-depressin substance, which was actually used originally against the shingles virus, herpes zoster, and actually then was actually used by the University of Texas about 30 years ago in the treatment of ME/CFS. We use Betamax, which is basically methyl B12, and methyl B12 and B6 actually seem to actually fit into the methylation cycle. We use lecteride according to Blasi of Barcelona's idea that the potassium-sodium balance is abnormal, and if we actually add lecteride in the correct ratio, it helps. And indeed, actually, patients with muscle fatigue and muscle pain are helped with this. Catapult is helped actually patients who have problems memory loss and concentration loss. As I said, the immunoprop contains glutathione, L-cysteine, and the immunoplus actually contains folinic acid and some of the other things which fit into the methylation cycle. So what is the role of the methylation cycle? It's basically the methyl group is in the methylation cycle supplies the body actually that it can coordinate metabolism and can coordinate particularly sulfur metabolism. And actually I was asked by one of our audience about hydrogen sulfide, and actually there's an interesting correlation about hydrogen sulfide abnormality that Kenny Demurlier tested in the gastrointestinal tract. This is the pathway of methionine to glutathione, and actually you see the folinic acid and glutathione and B12 fit into the process. Now, the study of gene expression, we heard actually that beautiful talk that opened the conference from Eric. But interestingly enough, my friend Jonathan Kerr, who unfortunately we don't know, he dropped out of CFS research a couple of years ago, and we hadn't heard from him for some time. But he had originally started actually the idea of a gene expression abnormality in this disease. And we found actually that in a joint research, I sent him the patient samples, and he actually did the lab testing, and we find actually that there was an abnormality in the genes. And he had a massive number of people collaborating in Britain. And John Sheehan and I actually helped by actually adding some research from the States. These were the 16 CFS-associated genes actually that Jonathan Kerr actually and our co-workers actually found. And we actually thought that we might actually produce a diagnostic test based on this abnormality. Unfortunately, as I said, Jonathan Kerr lost his position at St. George's Hospital in London, and the research actually slowed. Then we actually come to Judy's actually retrovirus testing in Nevada. First of all, what was the good outcome of that? Well, the good outcome was it produces actually massive, exciting press releases initially. And what did that do? It helped. Why did it help? Because all of a sudden, actually, there was a physiological aspect to this disease that was emphasized that had not actually been emphasized previously. So even though actually it proved to be a contaminant later, it actually did some good. And this is actually Elaine Fridas, who actually got applause earlier. I'm sure actually she would be delighted to hear that she still gets applause. And this was her original paper on her retrovirus 18 years ago. So, what's our ongoing research? Well, our ongoing research at Sinai is that we're actually looking at post-exertional malaise. We're looking at the immunology, we're looking at physiology, we're looking at virology, we're looking at gene expression. We've also actually got, personally I've got an HHV6 pharyngeal swab, actually sponsored by the HHV6 Foundation. We're looking at B12 changes with a sublingual spray instead of actually giving injections. We're looking at retrospective analysis of carnitine, and lately we started actually a SPECT scan with Fahrenheit. SPECT, single proton emission computerized tomography. This is a nuclear medicine scanning method of the brain, and actually we are looking at the limbic system in the brain. The limbic system hypothesis was started actually by J. Goldstein, also brilliant researcher, in 1993. What is the limbic system? It's that sort of peculiar system at the base of the brain. And it's thanks actually to Byron Hyde and Ishmael Mena that we actually started this single photon emission computerized tomography scan study. It's actually rather complex, the limbic system. I have actually an expert who flew in from London here, and Dr. Gupta actually is going to join the panel actually for discussions later. It actually is group structures, the hippocampus, the amygdala, the anterior thalamic, the fornix, and the basically the centers which are at the base of the brain. It supports multiple functions, including cognition, behavior, motivation, long-term memory, olfaction. It appears to primarily deal with our emotional life and has a great deal to do with short-term and long-term memory. And this is actually where the actual amygdala with the limbic system is. It basically is here. And when we actually look back at that astrocyte with the HHV6, this is an astrocyte in the brain. This is a brain cell infected by the HHV6 virus. So what is the implication of that? The implication is that if we look at a SPECT scan, we actually see this abnormal area. And what is that abnormal area? It is the limbic system. And it doesn't only happen in one scan, but we've actually seen it many times. And again, the actual blue and green area in the SPECT scan is abnormal. So and you can see actually there's probably a date up here. This is very recent. This is October, last month. So what are we actually going to try and actually determine from this? Well, it appears actually to be directly responsible for, as I said, cognition, emotional life, sleep, and memory formation. And limbic inflammation may be related to the immune system dysfunction, and in turn to post-exertional malaise and ME/CFS. Now, what is post-exertional malaise? Christian Becker is going to actually speak in a couple of minutes, and we're going to actually hear about what we're doing in our Sinai ME/CFS Center. But we'll actually see that we're going to try and support or deny the exercise therapy that has been suggested by the CDC, by PACE, and by NICE in Britain. And the problem is that graded exercise therapy can actually produce adverse results. And that's what we're going to actually try and actually determine. Is this actually indeed a positive method of treating this disease, or indeed can actually excessive exercise do harm? We know that exercise is good, but over-exercise is bad. So the specialties that are included in our group include exercise physiology, Christian, immunology, Maria Murad, virology. Dr. Singh actually originally was interested. She actually came from Salt Lake City. Genome research, obviously, by Eric. Serology, DNA, RNA, biomotion side. We've actually got a whole slew of data that we're collecting. We've collected terabytes, not zettabytes. Zettabytes actually was actually for the worldwide study. But hey, we're actually looking at terabytes. And for those actually who don't know what a terabyte is trillions of data. We've actually, we utilize massive amounts of computer power. And how do we actually monitor this? Well, I had to actually borrow this from one of my patients. Carol actually kindly lent me this Fitbit monitor. This is a Fitbit monitor. It's about 3 inches. And it's worn actually on the pocket, on the wrist, and it measures activity. And it basically tells us for the first time that we've got some objective measure of activity. And what do we do? We actually look at activity in patients. This is a very early a study where we actually just had a handful of controls and a handful of patients, and we subjected them actually to some exercise, And the controls actually showed very little change after the exercise. This is 1 day, 2 days, 3 days after the exercise. And this is the ME/CFS patient. Exercise, obviously, their level of activity is less, but immediately after exercise, their activity is considerably reduced. And if you actually then look at a patient over time, over 2 months, this is not actually a patient who has been stressed by exercise. This is actually a 2-month Fitbit output, and it's actually from the patient who gave me this. And you see, on one of those days, she naturally had to do something. I don't know what it was. maybe Carol will tell us. Anyway, there was some action at that moment, and immediately afterwards, her ability to do things actually was markedly reduced. Her post-exertional malaise actually is descriptively shown in this graphic output. We are not, Christian's going to actually amplify some of our findings, because this is a very simplistic early effect and early abnormality, and we're going to actually expand on this, and Christian actually will tell us all about that. So this is a multi-discipline group: Eric, Miriam, Christian, myself, and then I've got to actually thank several people. Jay Spiro, well, and you saw Jay came up and they actually sort of rescued me from my computer woes, and he's actually been superb actually in helping. He also actually unfortunately suffers from this disease. Laura Malilli has actually been with me 25, 28 years. Actually, she's my head nurse, and she actually knows this disease. Stacy is also a nurse, and we've got computer nicks and DNA and RNA lab staff who produce, as I said, terabytes of data. So basically, that's what we've been doing, and now it gives me great pleasure in introducing Christian Becker.
Well, it's a great pleasure to be here, and it's a great pleasure to get involved in ME/CFS research, which is really an area of research that is in huge demand of increasing work of the kind that Eric introduced this morning. So, I got it. So I'm just going to give you a 5-10 minute overview. So what we said we would do is we would take the blood of patients at baseline, then submit them to a standardized exercise protocol, and then sample their blood again 24, 48, and 72 hours after the exercise. In addition, we also collect intestinal stool samples and do microbiome profiling. And then, as a fourth aim, when we get there, we want to specifically look at graded exercise therapy and the effects on the immune system as well. So this is the protocol. We just completed the pilot phase and enrolled 15 patients, and I want to just take a moment to thank everybody who has participated so far. And 15 controls, which we matched by age, sex, race, and also by BMI, which is a body mass index, so it's a measure of height to weight ratio, body type, and indirect measure of fitness and activity level. And we had them enroll, and on day one there was a blood draw with all these different processes set in motion. Then there was this CPET stands for cardiopulmonary exercise test. The regimen is not a maximal exercise test, but a 70% maximal heart rate, so that simulates more what an everyday stressing activity would be as opposed to fatiguing exercise. And then we repeat the same measures when the patients come in a day later, 2 days later, and 3 days later. The reason that we did these 3 time points is because we don't know which of the time points is going to be the most informative one. So we consciously set this up in a way that we have this number of patients to do more time points to then, in the analysis phase, find out hopefully one most informative time point to then scale up the whole operation by 10-fold and look at 150 patients and 150 controls. We heard earlier that we need larger numbers of patients. So again, we have a sophisticated data gathering system with clinical questionnaires, fatigue scoring. We have the pedometer that Dr. Enlander referenced, the Fitbit. We might switch to a different, more sophisticated system in the main phase. We're going to get, we're getting blood at every time point. And then one of the other unique approaches, this is just to go briefly over, we have excellent matching of the pilot phase that we've completed so far, 15 patients and 15 controls. And we can see here that the groups are perfectly matched in all those parameters. So we're not just looking at whole blood, because we also had the notion that we might have a problem of signal to noise ratio. If we just look at measures in whole blood, we may drown out a signal that comes from a subset of immune cells. So we actually set up a system where we, and this is just to show that we had to really optimize this, because we can't obviously take large amounts of blood from patients at each time point, because then fatigue and malaise will be the self-fulfilling prophecy. It's just brought on by us taking too much blood from the patient. So we had to keep the number, the milliliters low to not have that happen. And then we have this system whereby we get whole blood, we look at the whole blood, sequence the RNA, but we also separate out different immune cell subsets that have been implicated to play a role in the disease, and then sequence those subsets individually without all the other cells being present, so that their signal isn't drowned out by all the other cell types. Because if we look in whole blood, then we always will get the signal of everything superimposed on each other. So Eric already showed this slide this morning. So we have an integrated database where all the pieces, the exercise physiology here, the clinical information that's gathered in Dr. Enlander's office, and then the assessment patients can us, the whole sequencing data and the other data shown here. And then we subject this, these are all the different pieces that are involved, and all the different data points that I've mentioned. We also have a component that I haven't even mentioned that looks at muscle enzyme profiles, the important aspect of the gut microbiome data, the immunophenotyping that's also going on. So every time point, the whole blood and the subsets get analyzed by different marker subsets, so that we can see how the numbers of the different immune cell subsets change in the blood. And how that may change with exercise. And then we take out these different subsets. We do the DNA sequencing, the RNA sequencing, and then we get all these different subsets. And then it all comes together, and like Dr. Enlander mentioned, we end up with about 4 terabytes of data per patient. And so we finished the pilot phase a little over a month ago now. And we're still busy looking at all the data. Just the immunophenotyping alone, it's 4 different panels, 30 patients, 4 different time points. That's 480 samples that need to be looked at. For the sequencing, it's even more. It's 720 samples altogether. It's 30 patients, 4 time points, 6 subsets. So we're currently really busy looking at the data, and it may be disappointing that I can't actually give any preliminary data, but we really are not ready yet to draw any conclusions. We're not at that point. But stay tuned. We should have some results fairly soon. And then we'll modify the approach. Obviously, the idea is that we can hone in on the preliminary findings of the pilot phase, and then modify the approach for the main phase. And that's where we are right now.
will answer 1.5 questions. I'll answer half, you can answer one. Jay.
Okay, so clinically, when we as patients go through this, these are the sorts of things that we have to do on a clinical level to prove to people that we're sick because of the societal perspective of the disease as well as the perspective of the disease from medical science. In the patient community, they talk a lot about the 2-day tests that are done by the people out in California, Stacy Stevens and Christopher Snell. I was wondering if you could tell us just a little bit about what you came to design the study that's a little different from theirs, and there are concerns because we hear from the CDC that they won't do that 2-day test that is considered to be important by a lot of people in the patient community, especially online. So I have no doubt that you designed a great study and that even with the 1 day that this is going to show how sick we are. But can you tell us something about the differences between what you saw in their design and how you designed?
Well, let me first start off by saying that I came into this not having treated, not having been involved clinically with patients with chronic fatigue syndrome, ME/CFS, and just meeting the 15 patients in the pilot phase, each and every one of them, it seems clear that there's something very specific, very real about this disease that is not just, explained by other ways. There's a phenotype here that to me, learning this as we went along, it seems reproducible and seems to have shared features. Now, to answer your question about the time points, ideally, we would have loved to get blood immediately after the exercise, about an hour after, 2 hours after, 3 hours after, and then on an hourly basis, for probably up to a week. Obviously, that's completely unrealistic. We can only go in with educated guesses in the end as to when changes in the immune system will happen. We know from other work in other areas that these changes happen pretty rapidly, usually, and that the symptoms may be delayed as an effect of what's unraveling very quickly. But in talking to Dr. Enlander and looking at his experience and years of experience, and when he said, well, actually we have patients too that experience this in a delayed fashion, and that's basically the reason that we came up with the 24, 48, and 72 hour time points. But ideally we would have liked to have more, but to limit it to 1 in the pilot phase, that seemed wrong. Because also what we can do with 3 different time points is we can see, if we see a change at time point 1, is that less pronounced or does it get more pronounced? So what's the temporal relationship? If we see an abnormality that is most pronounced at the 24-hour time point and then gets less, then we know we need to maybe look even earlier. Because we may have missed the peak and we only are seeing the downturn of a change. So
I'll accept actually full blame for this because 2 years ago, this didn't actually happen just last week. We didn't actually design this project last week. We designed this project over 2 years ago. So over 2 years ago, it wasn't actually completely clear that one set of exercise manipulations or 2 sets of exercise manipulations were key. At that time, we were actually much more interested in seeing actually post-exercise malaise. 1 day, 2 day, and 3 day post, as Christopher said. Christian said, we didn't know, and we still don't know, and nobody knows. In fact, actually, they're trying to tell us that post-exercise malaise actually doesn't occur. They're saying actually, go out and exercise. Go out and exercise more, and it's going to actually do you better. Completely wrong. Last question. Before I actually... Yes, sir. My patients actually ask all the most difficult questions. I should actually prime you before this comes.
So I'll apologize in advance to Dr. Enlander, but I wouldn't be doing my job if I didn't cause a little trouble. Is there?
You must be getting better.
Well, I've had this one cooking for a bit. is there a possibility of doing a study which includes a portable monitor which the study participant would take with them from the time of the very short, 20 minutes of very mild exercise stimulation, and which then would be able to see by some unknown means their state of well-being for the next 4 days, such as monitoring electrical activity in the brain, blood pressure, and perhaps some way that can gauge the experience that the patient has, which is not clear where it's come from. I will say that after a certain sort of stress, that most people who have this can verify, suddenly, somewhere within the next 48 hours, you're out like a zombie.
Yes.
The person is flat as if they are.
That's exactly what Christian said. We did anticipate this. Nobody can anticipate this.
Right.
We don't know whether 1 day, 2 days, or 3 days is appropriate for people in general or for that particular patient. Some patients actually have PEM 1 day later. Some patients have 3 days later. And as Christian said, actually, we can anticipate it. Thank you, Larry, for the question.
Well,
and I'm going to have to defer, actually, because